Good afternoon and welcome to the webinar. I am Cassidy Avila with the Center for Optimizing Rural Health at Texas A&M University. And we thank you for joining us today for Growth and Financial Impact of Your Swing Bed Program, presented by Stroudwater Associates. We will be leaving time for questions following the presentation, but please do feel free to type your questions into the chat during the presentation, and I will make sure that our presenters see them during the Q&A portion. As you saw, we are recording this webinar, and we will share a link to the recording and the slides in a follow-up email with you. So now, before we begin, I would like to take a couple of minutes to introduce our speakers. Zach Bozer is a former hospital leader passionate about helping small rural hospitals navigate the sea of change in today's healthcare environment. An expert in financial and operational analysis, Zach is drawn to the challenge of improving healthcare delivery for future generations through work with rural providers in their communities. At Stroudwater, Zach supports clients through services such as financial and operational analysis, strategic planning, and cost report review. Before joining Stroudwater, Zach served as Director of Finance for Cuba Memorial Hospital, a 20-bed critical access hospital with a hospital-based 61-bed skilled nursing facility in rural Cuba, New York. Our second presenter today is Carla Wilbur. Carla is an accomplished nurse administrator with a strong background in critical care, education, lean process improvement, and emergency services, and she joined Stroudwater in 2014. Carla focuses on supporting rural providers in quality and operational improvement initiatives. She has completed numerous facility assessments and process improvements in quality, care management, emergency department, and care transitions for critical access hospitals, rural and urban health systems, and provider groups. Currently, Carla leads process improvement efforts in the development of the clinical care delivery spectrum and workflow optimization. Carla is passionate. She is a passionate advocate for combating the opioid epidemic and a leader of the Stroudwater opioid management team. So welcome, Carla and Zach, and I will turn it over to both of you right now. Thank you for being here with us.
Thank you, Cassidy. I appreciate that. And thank you all for joining us. I will begin our webinar. Zach is going to advance our slides for us today. Thank you. So we're going to have a brief overview of swing beds, talk a bit about the general eligibility requirements, a lot on growing your swing bed program, and then importantly, some quality improvement metrics that are important for all swing beds. And then Zach will take us through some swing bed economics information, and hopefully we will have time for some Q&A. Next slide. So why swing beds? So all of our rural hospitals can provide an important resource for our patients and in our community. Our rural hospitals over the years have also seen a decrease in their acute care admissions. So swing bed does help with the capacity issues, helps to build our volumes in our rural hospitals by having a swing bed program. It gives our patients the ability to stay close to home for their families as well. And then, our access is then the care is coordinated through in our region, and we don't lose patients to another area. It has been known that swing beds help to reduce readmissions and avoidable ED visits, and help with a shorter length of stay. And for our critical access hospitals, swing beds help to comply with the annual 96-hour length of stay rule. And again, it's a good financial benefit to our hospital because we do build our volumes. Next slide. So unknowing the way that our healthcare system is moving with our different payment and payment reforms, and a lot of the different changes within our healthcare industry, our hospitals really do need a strategy to grow their swing bed programs. We at Stroudwater believe that in a typical environment, if your service area population is somewhere around 10,000, for each 10,000 in that service area population, rather, we believe that you should be able to support an average daily census of 4 in your swing bed. Now that is variable. It has a lot to do, again, with your specific area, whether or not you have a lot of skilled nursing facilities locally, and then a lot to do with your referral patterns and referral sources. But that's our target and our guide that we start with. Next slide. So the basic general eligibility for a Medicare swing bed patient must be that the patient is in Medicare Part A and have those benefit days available to use. There must be a 3-day qualifying stay. However, the 3-day qualifying stay has been waived during our pandemic. And the latest information that I saw was that we still have the waiver of the 3-day qualifying stay until mid-July at this point. Our patients must be Medicare age or disability disease eligibility requirements must be met. The swing bed admission condition needs to be the same as the qualifying stay condition. The patient that's admitted to the swing bed can be within 30 days of discharge. So for in that situation, it would be that maybe we have a patient that has been in our acute or an acute stay at another facility and they discharge and go home. But during that first 30 days, for whatever the reason, they need to come back for the same condition. They can come into our swing beds for additional help during that period of time. The patient's condition must meet medical necessity for your inpatient skilled nursing, rehabilitation, or a combination of both of those. Next slide. So a little bit about growing your swing bed program. We believe that it definitely takes a team. So we think that we should always have an interdisciplinary team of at least nursing, pharmacy, our providers, a business office, any of our specialty services, consulting services, supplies, equipment, whoever's managing our materials management and our equipment, case management, and UR. It takes a team to really build the program. We believe that we need to develop what we call a care spectrum, which really understanding what type of patients can be cared for in our facility. Next slide. So we believe that organizations should really take the time to do a deep dive. And so with that, you look at in your swing bed program, what kind of patients can stay in your be a swing bed patient, either from a referral source or within your own organization as well. And that again takes a multidisciplinary group of all of the different parts of our staff that are really stakeholders in our swing bed services. Next slide. So this is just an example. We have a lot of data from hospital swing bed programs that have joined in with us on collecting information about their resources. So understanding what type of resources your organization has will help inform your care spectrum. So do we have the resources necessary to provide a specific service? If we do, then that service matches, and we should be offering that particular swing bed service. Or do we have the necessary resources, but we're just not providing that type of service? And I could use, for instance, wound care. A lot of our organizations that we work with have found that offering wound care helps to grow their swing bed services. But the most important part of this is that the entire interdisciplinary team get together and really do a deep dive around what services we have at our organization that we're currently offering, what would we like to offer, and do we have the resources necessary to offer that service? Next slide. So this is an example of just maybe post-stroke rehab. All of the different questions we would have to ask ourselves. Do we have certain capabilities, certain competencies? Do we have the right equipment that we need for this particular service? This is just an example of a post-stroke rehab service that one of the hospitals answered all of those questions to really determine, could they offer that service at their organization? And this was being done while they were creating their care spectrum. Next slide. So the first and most important thing is that active patient pursuit. So we know that we have to be active in our patient pursuit. We have to reach out to our referral hospitals. We also, as part of that, we need to make sure that our providers understand our services so that they may be able to swing one of our patients that needs extended care. We also want to be that program where the referral hospitals see that we are pulling patients from them. They're not having to push patients to our program. And we need to make sure that we follow those patients that are transferred to a higher level of care so that they know that they can return to their swing bed program in their community. Next slide. So as I had mentioned before, this interdisciplinary team needs to follow a process for admission. So there is, and I'll go into detail on each of these, but there is what we call a pending discharge review, pharmacy review, business office review, rehab review, our physician review, and then of course our patient pursuit. Next slide. So the pending discharge review starts with understanding how many beds you have available at your hospital. So hopefully someone is responsible. Hopefully you have that dedicated swing bed coordinator or that person that's responsible for our swing beds. And each morning they will go in, look at the available beds, the discharges that are planned for the day, and that way they're able to reach out to our referral hospitals. So that can be done by that relationship that you've established where you can call, email, or if you do have a relationship with a tertiary center or a larger system that allow you to have access to their EHR planned discharges, then you're able to take a look at what they have planned for discharges and understand that those patients may need the post-acute care services in your swing bed, and then be able to reach out to that referral hospital and let them know that you do have those beds available. Next slide. And then pharmacy review. Now we're hopeful that all of these different reviews are going to go on simultaneously. So when the referral center has patients they need to place, and you've seen the patients that really do fit your service, then everyone needs to look at that patient's case to make sure that we do have the resources that where we can adequately take care of these patients. So the pharmacy review may be determining what type of drugs this patient's on. Do we have those drugs in our formulary? If we don't have what's necessary, how long will it take for us to get them? And in some situations, the referral hospital has sent what is necessary for the patient to get started until we can get the specific drugs that are necessary in the facility. So that's a good pharmacy review. Next slide. And importantly, our business office review. So we want to make sure that the business office is able to verify that if it's a Medicare patient, that patient has Medicare days available, receiving any prior authorizations for other insurance carriers when necessary, and make sure that we do have a qualifying admission for our swing bed services based on that patient's insurance company. Next slide. Rehab. Rehab is very important in knowing what type of rehab service this patient may need. It may be that the patient is coming in for just a medically complex situation that doesn't require rehab. Say, for instance, they're coming in with some long-term IV antibiotics, but they don't necessarily need rehab services. Regardless, we want rehab involved. Many times our patients may be coming in for other nursing skilled services, but we can see the opportunity for them to possibly receive some rehab as well. So we want our rehab service to do a review of the patient's case as well, and make sure that if the medical necessity is being met for rehab services, that we have the rehab services that they need. A lot of our small rural hospitals don't have OT or speech available all the time. So if this patient does need OT or speech and we don't happen to have that service, then unless we're able to contract with someone to have the service available while they're there, we won't be able to accept that patient. So we do need to do a good rehab review as well. Next slide. So at the very end, and if you've already established your care spectrum, your provider's on board with the type of patients that you can accept at the facility. So for the provider to review this, it shouldn't be a real problem. But you've already reviewed it, your business office, you've made sure that you have everything that they need as far as supplies, equipment, our pharmaceuticals, and then we will approach our providers and let them know that this is a referral that we have that we would like to accept, and make sure that the provider then believes that they can confirm the medical necessity for the swing bed services. Next slide. At that point, it's patient pursued. So we want to be able to respond to our referral hospitals as quickly as possible. There may be cases where you're not able to take that patient. And in that situation, we still want to continue to communicate with our referral hospitals and continue to build that relationship with them. The quicker that you're able to respond to the referral hospitals, the better, because these hospitals that are full and they're really trying to get these post-acute care patients out into their swing bed services, they want a quick answer, a quick turnaround. Otherwise, they'll go to someone else. So we want to be that hospital that answers very quickly whether or not we're going to be able to take the patient, and continue to build on those relationships as we go forward. Next slide. So a little bit about quality improvement. We can't have a really good swing bed program without looking at our quality metrics. So what I'm showing here is the 2021 average for the data that we have in our outcomes analytics. So we collect a lot of data that our hospitals that work with us on their swing bed outcomes. And we pulled this together for 2021 just to show some of the metrics that we believe really need to be monitored. So we want to look at our average length of stay for sure. If we have a very lengthy length of stay, why is that? What kind of patients do we have that has lengthened that length of stay? On the average, you see about 10 to 12 days. Some of our hospitals have long-term antibiotics, and that's their niche market. And so they may have a much longer length of stay. And then some of the hospitals have short cases where they're just going to need to be in for about a week. But on the average, we see around 12. Interestingly, although a good number of patients are admitted for other reasons than therapy, therapy is, our patients, 99% of our patients that we have in this database have received some form of therapy. And as I mentioned earlier, there are many times where a patient may come in and they're not specifically there for therapy, but as it turns out that they do need some form of therapy. And so that's another benefit of having a good therapy program there. Looking at the improvement scores. So we use the section that is just like the MDS for the PPS hospitals programs and skilled nursing facilities use, the section GG of that MDS. And what would that self-care and mobility score look like? What type of improvement do we see? That's something that is very important to monitor. It helps you know, are we seeing improvement scores that demonstrate that we are helping our patients improve and that they're reaching their goals that they've established. It's really important that we do our med recs on admission and on discharge. They're highly important. And then really important for us is how many patients are we able to send back home? If they come in from home to their acute stay and then to our swing bed, we want to be able to get them to a place where they can successfully return to home. Next slide. So this data that I've just shared comes from the database that we have where we collect all of these different metrics through our swing bed outcomes. So there are, we wanted to show for our option 1 that includes what's listed there. There were 83 critical access hospitals data in that 2021 information. And then the other information that I just shared also comes from what is known as option 2, which includes all of the basic information, but then some deeper dive into some other information as well. And that database included 76 critical access hospitals. Next slide. And I'll let Zach take it away on some swing bed economics.
Thank you very much, Carla, and good afternoon, everyone. It's great to be with you today. So for this section, what I want to do is, kind of tie together the presentation. So Carla has spoken about, the importance of the swing bed program for your rural hospital. We've talked about the importance of identifying the care spectrum and those patients that we're able to take in our swing bed program. We talked about some of the ways to grow the swing bed program and some specific quality metrics. But the missing piece that we haven't discussed yet is the financial aspect of things. And that's what I'm going to get into here in the next section. So one of the things that, a lot of hospitals that Carla and I work with, Carla being the clinical quality side, me being the finance and operation side, is that we find that the biggest barrier to swing bed program growth is the siloization between those two separate departments. So oftentimes we'll see that, maybe the clinical department is looking to grow the swing bed program, following some of the things that Carla has mentioned, looking to put some resources into action to be able to grow that program, but we're not, fully understanding what is the financial impact. And in order to be able to get buy-in from the CFO or the operations team, what is the ROI on the resources that we're going to allocate for growing our swing bed program? And that's something that's really important here. And it's making sure that we're elevating the importance of development of a swing bed program at the hospital, senior strategic level, making sure that that is a priority within the organization. This is something that I can speak to specifically as my time at my hospital, is that, we had made it a really important initiative across the entire hospital where everybody, not just, nursing, not just C-suite, that, the organization knew that it was a priority that we were going to grow our swing bed program. And by making sure that we have all the right people at the table, all working together, both from the clinical side and the finance and operational side, to make sure that we achieve that goal, that's going to be the number one thing that's going to allow you to grow your swing bed program. So, as we talk about the importance of the swing bed program, it's this opportunity to increase the amount of inpatient rehab and skilled nursing services that we're able to provide within the different communities that we serve, making sure that we're able to keep patients locally when we're able to. Obviously, if we're able to grow our swing bed program, there's opportunities to increase reimbursement. And, as Carla mentioned earlier on with the length of stay management, especially for critical access hospitals, as we're bumping up against that 96-hour limit, this is an opportunity to shift patients into a swing bed, swing them into the program that they're not ready to be discharged yet, but they can't stay in an acute bed any longer. Another important opportunity here is that with the inpatient unit, if we think about that, it's largely a fixed, really high fixed cost within our nursing unit, and step fixed costs as well. And I'll speak to this on the next slide. But, for the most part, we're operating largely with, fixed minimum staffing. And so as we're able to grow our program and, become more efficient in the way that we're delivering care for swing bed services, we're taking those fixed costs and then we're dividing them by in the numerator, those fixed costs of providing care, and we're dividing that by a growing denominator, which is decreasing the cost to provide care. Now, regardless of if you're a critical access hospital or a rural PPS hospital that offers swing bed services, we have the same imperative. We want to deliver care more efficiently. And, specifically for critical access hospital, the financial benefit will occur that as we grow our swing bed program, excuse me, we're increasing the percentage of our inpatient costs that are reimbursed on a cost basis. And so this is essentially increasing our cost-based payer mix. And, this reduces the overall unit cost of providing care by diluting those services. And if we're able to lower our unit cost with each additional day, we're becoming more efficient in delivering that care. That's going to create a lower cost of care and create those additional efficiencies, which when we think about our acute commercial reimbursement of acute days, that for those fixed fee structures, that as we are able to deliver care more efficiently, and if, for any of my cost report people in the room, that if you think about the routine cost of care on your cost report, as that goes down, you're actually increasing your profitability on those fixed fee acute patients because you're getting that same fee regardless of how much it costs you to provide care. And it's the same thing for PPS hospitals, that we have fixed fees that we're receiving for caring for patients. And as we increase our volumes and we're able to care for those patients more efficiently and more cheaply, we're increasing our profitability on those patient days. So on this slide, I'll talk a little bit about fixed versus variable costs. So fixed costs are those that we have and exist regardless of our volume. So whether we have one patient on our inpatient unit or we have 12 patients on our inpatient unit, we're going to have unit staffing, at least a fixed minimum. We need to have a medical director. We need to have certain par levels of supplies, and we need to have the equipment ready to be able to care for patients. I also mentioned step fixed costs on the previous slide. So these are fixed costs that as our census grows, so say we have 2 patients on our inpatient unit, as we grow our census to say 6, that we're going to need to add additional staff in order to be able to care for those patients. And so we have a step up in our fixed costs. And then those costs are fixed at a certain level until census reaches a new threshold to which we need to increase more staff to be able to care for those patients. So that's the step function of fixed costs. Variable costs, on the contrary, those are the ones that with each additional patient day that we're going to occur, they don't exist until we take that next patient. So these are the incremental medical supplies. So if we think, we have a swing bed patient and they're going to be with us tomorrow, what is the cost to care for them tomorrow? It's going to be incremental medical supplies that they're going to need. It's going to be drugs that they're going to need. It's going to be the food for their patient meal that they're going to eat. It's these specific things for those costs that are variable. And in comparison to fixed costs, our variable costs represent only a tiny fraction of our total inpatient costs. And so as we're able to grow our swing bed program and volumes, pick up, that our fixed costs are being diluted faster than our variable costs grow. And I will show an example of this later on in the presentation. So this one, again, is for critical access hospitals, but up to this point, I've kind of talked a bit about the cost-based nature of swing bed patients. But we also have these non-cost-based swing bed days, or these swing bed NF patient days that are non-Medicare or Medicare Advantage. And, if we think about cost reimbursement, even if the critical access hospital were to be 100% cost-based, that's only ever going to allow the hospital to break even. And over the long term, break even is not a sustainable proposition. And so we need to look for ways to generate profit and margins across different services at the hospital. And these non-Medicare, Medicare Advantage, non-cost-based days are one opportunity to do that. And so this involves, a say commercial contract. That one of the things I often will hear when speaking with critical access hospital CFOs is they'll say, hey, Zach, if my cost-based rate for swing bed is say $1,000, looking at the example off to the right here, and I know that that represents my cost to provide care, if I accept this Blue Cross patient where I have a commercial contract for only $500 a day, am I losing $500 a day by accepting that patient? And oftentimes I'll hear that swing bed programs they're not accepting these referrals based on that analysis. And what we should be doing is taking those contracts and comparing those to the statewide Medicaid NF carve-out rate. And you can find this on your cost report, but for most states it's somewhere between $200 and $250 per day. And the way that this works on your cost report is that any non-Medicare, Medicare Advantage days, these swing bed NF days, are carved out of your routine costs, which determine whatever your cost-based rate is at this $200 to $250 rate. And so rather than comparing the 1,000 to the 500, we should be comparing the 500 to the $250 rate in this case, which allows the hospital to generate this $250 profit per NF patient day in the example. So, this is the same principle for PPS hospitals that have those rates. That what we're looking to do is, if the contracted commercial rate is greater than the NF carve-out rate, or is greater than the variable cost that we're going to incur for that next patient day, say maybe all of the food and pharmaceuticals and medical supplies for a swing bed patient for the day is only $200, $250 a day. If we have a $500 contract, we're generating positive margin for the hospital. Now, this is a breakdown, and again, this is of critical access hospitals, but again, rural PPS hospitals that offer swing bed services, they're very similar to critical access hospitals in the sense of the services they offer, the size of the hospital, the geographic location of critical access hospitals. But as Carla had mentioned, that from the work and experience that we have in the field from working with hundreds of rural hospitals across the country, we look for this average daily census of 4 swing bed patients per 10,000 of population. And we see graphically here that all of the little dark blue squares are critical access hospitals that meet this 4 per 10,000, and the little orange or peach type squares are the ones that are below that target. And again, if you have a small service area of say 5,000 people in your primary service area, you're only looking to essentially achieve an ADC and a swing bed of 2.0. So although we see a lot of hospitals meeting this threshold, there's a lot of them that aren't meeting this threshold. And so there's a lot of opportunity to grow swing bed services at not just critical access hospitals, but a lot of rural PPS hospitals across the country as well. And so to tie it all together, I'd mentioned that there's an example here. And again, this is for a critical access hospital. But what we did is we worked with a critical access hospital in this case, where we built out their cost report from the inpatient unit. And we looked at, what was your swing bed census prior to growing your swing bed program? So we have 2 scenarios here. We have the base case, kind of pre-swing bed growth, and then we have the swing bed growth scenario, where they grew swing bed census by an average daily census of 2. And what we see looking at the base case is that, we look at the swing bed census 3.1 on that third row there is the swing bed SNF census. We see that they had fixed costs of about 6.7 million, variable costs of 920,000. So as I mentioned earlier on, that your variable costs are only a fraction of your fixed costs here. And we see this playing out, real time in this example. We see that the inpatient cost per day is about $1,815. And that we see that the profitability or the net margin of this hospital's inpatient unit was a negative 592,000. Now, once this hospital had grown their swing bed program, we modeled this out again, and they had grown by an average daily census of 2. So again, using the same logic here, you can see in the third row, we've increased that to 5.1 swing bed census. We see that the fixed costs are still 6.7 million. Again, they're fixed, so they wouldn't change. We see that our variable costs did increase by about 130,000. So not very much, but we also, looking down below again at the inpatient cost per day, we see that the rate has gone down from 1,815 to 1,567, or about $250 per day. So as we're adding those incremental 750-ish days, it's diluting down those fixed costs faster than those inpatient variable costs are growing. And that is lowering the rate per day. It's increasing the efficiency of providing care on this unit by increasing the number of swing bed days. And it's generating this positive margin of an additional $271,000 for this hospital, increasing profitability from a negative 592 to negative 320, because we're increasing the percentage of those patient days, or those, inpatient costs that are reimbursed on a cost basis, while creating efficiency that's allowing us to gain profitability on those fixed fee commercial reimbursements, say for acute patients, that now in this second scenario, we're providing care $250 cheaper. Thus, we're increasing our profitability on those fixed fee reimbursement by $250 per day. And, so again, to sum it up, that by going through the processes that Carla has outlined above to grow our swing bed census, and then model out what that looks like from the financial perspective, this is how you gain the buy-in of the entire organization to say, hey, there's a multi-six-figure opportunity here potentially that, as a rural hospital that is, having difficulty achieving positive operating margins, this is something that we really need to prioritize and implement within our hospital so that we're able to sustain the organization going forward, grow new services, be able to hire and attract the staff that we want to have, provide raises and purchase equipment and all those different types of things that we need in order to be able to provide care in our communities, not just today, but into the future as well. So at this time, we would like to open it up for any questions that the audience has.
Thank you, Zach. Thank you, Carla. Let's see, I don't have any questions in chat at the moment, but I do want to encourage you to go ahead and either unmute or raise your hand or put a question in the chat if you have one. We definitely have time, and it was a very interesting and informative presentation. Okay, so we do have one question that has come through. It says, for a patient to be admitted into swing bed within a 30-day discharge from a hospital stay, would you need new PT/OT notes?
Okay, so I'll take that, Zach. I would think that you would want new PT/OT notes if they are going to need, ongoing PT or OT care. If that patient was admitted back within their 30 days, remembering that they have to still meet that same condition. So if they were originally admitted in your swing bed for PT, for let's say, some type of trauma care or PT for a total hip, knee, whatever the case may be, and that's why they're coming back to your swing bed program, then we would definitely want new notes so that we can justify the need for them to continue to receive services. I'm not sure that I've ever seen anything that says that there is some type of rule, but I can say that we would have to show that medical necessity. So that's going to be really important that you have those notes.
Excellent, thank you.
Mentioned that.
Okay. Are you seeing this question?
Yeah.
Okay.
I do. Oh, okay. So there are a lot. So there have been hospitals that have, considered their niche program wound care. Others that have focused on long-term IV antibiotics. I work with one hospital a lot. They're in one of our networks, and that particular hospital survives on long-term IV antibiotics. They'll have an average daily census of 14, and they're all IV antibiotics. So this happens just to be their kind of niche market. There are so many other things. There are hospitals that have actually developed a swing bed vent program. You can take new trachs. I think one of the important things to understand is that there are many other reasons to skill a patient for your swing bed service than rehab. Rehab has been known to be the go-to, and that's great. I mean, we have used rehab services a lot for our swing bed patients, but there are patients that have an acute care stay and that need ongoing care that don't necessarily have to have rehab. Think about services such as a new ostomy, and they need to be taught ostomy care. Teaching is an allowable skilled service if it needs to be done by a licensed person, such as a nurse. If you have that patient that's on a new medication that is very difficult to manage, that person can be skilled for your swing bed service while that management and evaluation is done. And that has to be done by a licensed person, so that can be done by a nurse. So there are a lot of different ways in which we can skill patients, either swinging them from our acute service or market those services that we have where we would take patients from a larger facility that really need to get them out and get them placed.
Thank you.
Mhm.
The next question reads, what is the rule for using swing bed for end-of-life care? Is it allowable?
It is. Now that has to be for skilled service, of course. So if that person is receiving IV pain management, then yes, of course, they can be skilled for that. If the patient, and there is a statement in the regs that speaks to maintaining their abilities. So you don't always have to have a patient that comes in where we're trying to improve. I mean, that's ideal, of course. But if you have that end of life patient that has become a little bit more debilitated, and they could use some therapy to help strengthen and maintain where they are, then they can come in for that. That's where I've seen end of life care in our swing beds, mainly pain management. That's IV pain management, or for some strengthening and maintenance of their strength and ongoing maintenance. It's not to make them better, and we know we're not going to solve that because they are at their end of life, but we're helping them to maintain.
Thank you. And the next question reads, does the facility have to provide transportation to doctor's appointments, et cetera?
Well, that's a decision your facility needs to make. So if that patient is going to require doctor appointments, and that's something that when the referral hospital sends you that particular patient, and you're looking through all of the information to make that decision, and they're going to have ongoing appointments, then that's something that needs to be discussed. Is the family member or are there family members or caregivers that are willing to take them to doctor's appointments, if that's the case, if you don't have transportation services? If they don't have family members to take them, and you don't have transportation services, and you're not going to be able to do that, then no, I wouldn't accept that patient, because we do have to manage their care. And if that's something that needs to be done. And now I have seen hospitals that have been able to, for certain appointments, and it doesn't work for all appointments, but for certain appointments, they've been able to manage that through telehealth.
Excellent. Thank you. And the next question reads, can we bill for wound care in SWB setting if it is done by a certified wound care nurse, or is it built into the per diem/room charge?
Zach, would you feel comfortable answering that? My answer to that would be that that we, of course, document everything, and there are charges that are associated with that as far as the costs, but that it does roll up into the per diem.
Yeah, Carla, I would agree with that.
Great. And then the next question reads, where does anyone get their training for their staff to start a vent program?
Well,
yes.
I can look into that and let you know. I know a specific hospital that I've worked with before that did that. So if you would like to email me, then I'll have your contact and I can connect you with that particular hospital.
Great, that's very kind. Thank you. Let's see. The next question reads, I know that you need to have qualifying skilled needs for skilled care, but do you need to keep track of swing bed patients on UR programs like Interqual or MCG throughout the stay?
No, you would need to make sure that the provider has written for their medical necessity for skilled services, and that that's that physician certification when they move into your swing bed program. But I don't think that it's specifically like you are for acute. You would want to make sure that you are keeping up with their days, because the patient does have to be, the swing bed patient does have to be notified when they're close to using all of their benefit days, because then that's a discussion for the patient and the business office, in that are they going to pay out of pocket, or how is that going to work after that, and then continually making sure that that patient is still meeting medical necessity. But I don't know, hospitals are using Interqual and MCG just like they do for acute.
Thank you. And the next question, is there a Medicare star measurement for swing bed programs similar to SNF 1 through 5 star ratings?
No, unfortunately not. Now, the reason that Stroudwater originally started our swing bed outcomes project work was exactly that. Swing beds to date haven't had the star, if you will, rating. So there was nothing that could really compare them to SNFs. So that was originally why we started our outcomes project so that we could collect data and then compare ourselves. We did a study with the university in Minnesota on that as well, so we could compare ourselves, swing beds to SNFs. Now, there are some organizations that have started developing what they're calling a certification program, so that they can your swing bed program can market that they are considered that swing bed certified. I don't know any of the programs yet that have done that. I'm sure there probably are some, but we work with swing beds across the country, and I haven't run into one yet. What we recommend is that you begin in one way or another, whether it's in our swing bed outcomes database or on your own, that you collect quality data so that you can market your good quality programs to these referral sources. As you know, there was a condition of participation that came out now a couple years ago or so, which requires all of the hospitals, including PPS and CAUSE, all hospitals that are going to send their patient to any post-acute care service, that they have to be able to supply the patient and or family member with quality data so that that person or their family can make an informed decision. So it's up to us, as we're growing our swing bed programs, to show our quality scores and make sure that the referral hospitals have access to our quality scores. Whether that's something that we advertise and share with them or otherwise, so that they can make those informed decisions and can see that, we deliver really good quality. We have low readmission rates from our swing beds. We have very little in the way of ED visits. We have a good return to home rate. We don't have skin breakdown. It goes on and on, like the list that I showed earlier. But those are the things that are really important for you to demonstrate as part of your program.
Yeah, and I would add on that too, that, for as important as it is to be advertising or, marketing how high quality of a program we have with referral centers for the reasons that Carla mentioned, it's also important to collect that information and show that we have a lower length of stay, and we have a higher return to baseline, and just overall higher quality. Because one of the things that Medicare Advantage payers like to do is deny swing bed status because it's a higher cost of care than, say, a skilled nursing facility or a nursing home. And so they look at that and say, well, why would we pay for a swing bed stay when it's so much cheaper to care for the patient in a nursing home? And so in order to combat that, to show them that we are higher quality and that we, despite the higher cost, it is worth the investment, that, oftentimes is a much shorter length of stay, that in the long run, it's going to be cheaper to care for the patient in a swing bed. And so it's really important to be able to demonstrate that to those payers as well.
And Zach, that's a great point. And I think you answered one of the questions that I see in chat about the Medicare Advantage plans not allowing patients to use their full 100-day benefits. So I think that's that's another conversation with them around your other types of quality, and that why it's not as expensive as what they think it is.
Thank you. And the next question says, are there many small rural hospitals that are not CAUSE that have a swing bed program? I'm guessing it's not as lucrative, but does it make sense for a PPS hospital to have swing beds?
We do have a lot of PPS hospitals that have swing beds, Zach.
Yeah, in my experience, there's clearly not as many as critical access hospitals, because I can't think of a CA off the top of my head that doesn't have a swing bed program. You're right, it's not as lucrative because if we think about the cost-based impact for critical access hospital, often that Medicare rate that is paid by Medicare and Medicare Advantage, which represents a significant percentage of that payer mix, is at a much higher rate than a PPS hospital would have. But I think to answer your question, does it make sense to have swing beds for a PPS hospital? It makes sense if you have excess bed capacity and that you're able to deliver care cheaper than, what your reimbursement rates are with payers. I mean, if you're good at negotiating payer contracts and providing care efficiently, then yes, it does make sense. Again, going back to one of the examples I was sharing earlier on, even that $1,000 Medicare cost-based rate for a swing bed at a COB, that's only essentially break even. You're not making anything on that cost-based reimbursement. You're getting reimbursed for your cost. Where for those non-cost-based days or for, a PPS hospital, you're generating margin based on the difference between your contracted rate and your cost to provide care.
So, and in addition to that, I think we also, if you do have, excess bed capacity, I think we also need to think about our staff and are we sending staff home when our census drops a bit? If that's the case, then how would that help to keep our staff busy and our staff, in the facility instead of calling them off? So there are other variables that need to be thought about as well.
Yeah, I mean, it's a great point. I mean, oftentimes, I think back to my hospital specifically for therapy, in a lot of rural hospitals that, it's difficult to find therapy staff, find therapists and such, whether that's PT, OT, speech. So when we find them, we hire them. And even if they're not full, and so we need them when we need them, but there's often can be a significant amount of downtime there. And so by providing swing bed services, that is an ability to help, fill them up and create efficiency among your organization as well to better utilize those staff members.
Thank you. And the next question says, do you know of any good swing bed MDS training courses?
I do not have one that I specifically recommend, but I can reach out to some of my other hospitals. And if you'll send me an email, I'll get some information for you.
Perfect. Thank you so much, Carla. Next question. Is there a minimum amount of minutes PT has to work with patients if the patient status is only rehab?
Most of our hospitals strive for an hour a day. Now, that does not have to be all in the same time because many of your swing bed patients may not be able to take one solid hour of rehab. So many of the hospitals break it into segments. So they may do, even 15-minute segments for their patients. It's whatever the patient, can tolerate.
Thank you.
They usually do about an hour, 5 days a week.
Thank you. Sorry about that. I know you mentioned that you thought Zach answered this question about Medicare Advantage. Did you feel it was answered in full, or would you like me to read it? I'll go ahead and read it. You can just tell me if you've already answered it. We have some patient access issues related to our independent swing bed program. These Medicare Advantage plans are not allowing patients to use the full 100-day benefit at our facility. What strategies do you use to encourage them to offer it to their patients?
Yeah, I guess I would, kind of refer back to the previous answer that I had. It's working with payers to make sure they understand the value of the swing bed program that we offer.
Perfect. And then 2 more questions right now. Is transportation a billable service if it's non-EMS transportation?
Not to my knowledge.
No, it's to mine too, Zach.
Yeah, not at my hospital, it wasn't.
No, it's kind of, if you're paying for that, that's rolled up into your overall costs.
Perfect. And then are we required to provide all medications, including home meds? Can patients take their own home meds if they are not on our formulary?
A couple of different answers there. So yes, we do need to provide all medications, including home meds. And yes, they can take their own home meds. You need to have a policy in your hospital for your program around patients and home meds. I will caution you that if their home meds are narcotics, that if you have them, and you need to still have them locked like you would do any narcotics. They can't be in, and I wouldn't leave any home meds at the bedside, but those specifically have to be treated as you would other narcotics. We ran into a hospital, and this recently, that they were given their patient their home meds and the narcotics, all of them for one day at one time, because the patient used to take them at home when they wanted, like they weren't on their normal every 6-hour schedule. So that won't work. So yes, they can take their own home meds. You need a policy around home meds. Home meds should be reviewed by your pharmacist before they're given. And you must lock up your the narcotics like you would any other narcotics.
And it looks like that is all of the questions that we have. Someone did make the comment that Elevant has some excellent educational resources. This individual is a CAW, and they contracted them with them to build their program. So
yep, they do.
Sharing that. Okay, I think that's it. I did go ahead and include a link to the survey for this webinar. It takes about 60 seconds. You can take that now or later if you don't mind. We would greatly appreciate it. It just kind of asks what you thought about the webinar today and what you might like to see in the future. I'm also going to share one other link in the chat. The Vulnerable Rural Hospital Assistance Program, which is the grant that CORE works off of, is accepting applications for our year 5 cohort. And so I linked you out to the application portal if you want to check out the FAQs and see if you're eligible or if you have an interest in that. And I think unless Zach or Carla, unless either of you have something, we'll go ahead and let everyone go. But I really appreciate your time, your response to all the questions. They were excellent. It was a fantastic webinar.
Thank you so much.
Thank you very much. Yeah, I want to say thank you, Cassidy, and thank you everyone for your time today. We really appreciated speaking today, and certainly reach out to us via email if you have any additional questions, and we will be sharing the slides after this presentation as well. So you'll have those. But thank you very much. Have a great afternoon.
Thank you all.
Bye-bye.
Bye-bye.